where you get a 59-year female who had a person who had undergone surgery for diverticulitis. So diverticulitis, Hartmann's was done. Now patient is having low BP and tachy and fever. So what you are suspecting, this patient is having sepsis. So patient has got septic shock. Now what can be the septic shock is the refractory. This is hypotension, and not responding to fluid restriction needs vasopressor. What is sepsis? Sepsis is a septic is systemic inflammatory response syndrome, SIRS. So definition of the septic shock is, according to the protocol, you have to measure Q SOFA. So Q SOFA gives quick SOFA score. This is a high risk patient in the hospital, multi-respiratory infection outside the ICU. 1 point each for 3 criteria. What are the 3 criteria? 1, 2, 3. So one is BP, and second is respiratory rate, and third is altered mental status. So what is the parameter? Should be BP less than or equal to 100, respiratory rate more than 22, GCS you have to measure, altered mental status. Then there can be the questions regarding this diverticulitis. How can be the lining? Simple columnar epithelium. What is the layer below mucosa? It is submucosa. Contents are blood vessels and arcades and connective tissue. Abscess is the localized collection, exudate neutrophils and all this. Contents inside the abscess is dead necrotic tissues. Why it's all dependent in the pelvis? Because of dependent area. So what kind of diverticular diseases? Diverticular diseases and diverticulitis. So difference is, it is just outpouching, and then if infection is there, it is diverticulitis. If the patient deteriorates, hypotension, tachycardia, bleeding tendency, possible cause can be sepsis, TIC, or any other disease. What is endometriosis? Endometriosis is abnormal. The endometrial tissue at the other sides, it leads to bleeding and pain. So there can be different theories like regurgitation, benign, and all that. Tissue samples from the operation site show neutrophils, so it is an acute inflammation. What are the type of granules? Primary granule, toxic mediator. Secondary granules are specific granule, toxic oxygen compounds. How long lifespan of the neutrophil is in hours? 12 to 16 hours. Enzymes are lysosomal enzymes. So how do neutrophils arrive? Neutrophils has got the different roles like margination, adhesions, and transmigration. So these are all inflammatory. How interpreted diverticulitis? It has got Henke or Henke 1, 2, 3, and 4. So 1, 2, 3, 4. One is limited conservative, second is drainage, third can be done by laparoscopy, fourth needs the. So neutrophils are produced in bone marrow. This is about the sepsis. The next station is male patient, HIV positive, or it can be HBS or HCV. Groin mass, and because of injections. So this is nothing but about pseudo aneurysms. So questions will come like, what type of HIV is the virus? HIV is RNA virus. It is single stranded. There are 2 types, 1 and 2. Then characteristic of HIV is single stranded RNA, retrovirus transmitted through blood, semen, vaginal fluids, anal mucus fluids, breast milk. So these are the things which questions can come. What are the causes of true and false aneurysm? So aneurysm can be true or false. So true, all the layers. So arterial wall has got, if this is an artery, so it has got 3 layers. This is media, this is intima. So this is adventitia. When all 3 layers are bulging, then it is true aneurysm. So this is true. So it can be because of Marfan's Ehlers-Danlos. These are congenital. Atherosclerosis may also lead to rheumatism or infection like syphilis. Now, what about false aneurysm? So, this occurs by damage leading to contained hematoma. So, whenever someone is breaking from outside and this wall, external wall is damaged, so there can be damage and there is only few layers are increasing. A difference between former weakening dilation over all the pseudonism collection between media and adventitia. So generally this is collection in between the media and adventitia, outer and middle layer, because there is a damage when you are breaking inside in just there is collection. So basically media had caused the elastin layer. So pseudoaneurysm layer affect it is intima and media, blood contained only by adventitia and surrounding tissue. Why do you have bleeding? So it can be, why does a bleeding? Trauma, infection, coagulopathy, hepatitis virus. So precautions to stop the bleeding. In this patient, this is HBS or HIV positive. So you have to take precautions, universal precautions, hand washing, wearing the gloves, protective gears, mask and everything. You keep pressing on the wound, but bleeding is not stopped. So it can be coagulopathy. So coagulopathy, it happens mainly because there is deficiency of vitamin K dependent clotting factors. So these are 10, 9, 7, 2, 1972. These are vitamin K dependent clotting factors. So this causes most of the time extrinsic. 7 is basically related with the extrinsic pathway, and there is the injury, and so clotting happens. There is a sequence in clotting. So how does it occurs? Whenever there is injury, that leads to platelet first, then clotting cascade is started, then there is final clot which plugs the vessel. So coagulopathy deficiency, decreased CD4 count or liver cirrhosis or something in the liver failure. So what are the symptoms of cryoalbuminemia? So what is this question about cryoglobulinemia? Globulinemia, deficiency of cryoglobulinemia. So this is a increase in blood viscosity, decreased blood flow tissue, hyperviscosity, headache, confusion, blurring vision. So deposit in small vessels can be plaguing infection, necrosis of tissue, particularly skin, ear, dexter, and deposit in endothelium the blood vessels, cryalbuminic vasculitis. So it is vasculitis, glomerulonephritis. It can be peripheral neuropathy. So blood flow into the lymph nodes. So lymph node has got a structure like this. This is cortex, this is medulla. So the blood enters from the afferent and this is the efferent. So entering lymph from the afferent lymphatics. Lymph flow, this is generally lymph flow. So lymph is entering from here and leaving from the efferent. So bleeding tendency in HIV is because destruction of the platelets and megakaryocytes. Whereas platelets are decreased, megakaryocytes are decreased, immunocompromised patient, endothelial injury, and all this leads to bleeding tendency. Stem is straightforward abscess. So forearm abscess is there. So it is the collection of pus. Pus is collected into the enclosed cavity. It is because of pyogenic organism and infection necrotic tissue. How to differentiate between cellulitis and abscess? There can be abscess or cellulitis. So staph aureus and streptococci, these are the two different things. Then this can happen in coagulase enzyme. The enzyme is coagulase, and here the enzyme is fibrinolysin. Then it is thick yellow pus, and here is thin pus. So what is the definition of pus? Pus is the defined pus. Acute inflammation comprises solid and liquid parts. Solid or liquid parts. So live and dead bacteria. So this can be clotting factors and all this. So yellow means Staph aureus. So generally colors yellow. There can be green or there can be silver. So yellow is staph, strepto something, this is pseudo, and this is actinomyces.
So the collection, it can be color of the pus depends upon the organism. What are the causal abscess? This can be bacterial infection, Staph aureus, pyogenes, non-bacterial, viral, fungal or parasitic. Pseudomonas cause green color. Why do pseudomonas? Green color is because of pseudomonas. It is because of myeloperoxidase. This enzyme is secreted, so that causes green color. Pseudomonas. Then what are the causes of non-bacterial? It can be non-bacterial. Virus, fungi, parasites. How to treat an abscess? It has to be done by antibiotics, then culture it and since conceal vanish. What non-antibiotics are required if the patient is having sepsis or toxicity, temperatures more than 38, hypotension or tachycardia.
This is about the station, 51-year-old lady and admitted with persistent venous ulceration affecting the distal left leg. Long-term intravenous drug user. So ulcer on the leg, she is HCV positive. So it is about hepatitis C. So it is the inflammation of hepatocytes. These are the cells and cause the virus and pathogen transmission. It can be intravenous drug abusers, unprotected sex, or middle sticks. So transmission is almost not due to screening of the blood. Blood transfusion is not there. So what about hepatitis C virus? How it is there? It is again an RNA virus and caused acute hepatitis, chronic hepatitis, and there can be acute or there can be chronic. So acute hepatitis presents with jaundice. So what happens in jaundice? Mixed conjugated bilirubin or unconjugated bilirubin, both are there. So mixed, there is dark urine because of conjugation, and fever, malaise, elevated, increase, ALT, AST, all that. And chronic hepatitis, symptoms which last more than 6 months, cirrhosis, hepatocellular carcinoma, if it may lead to hepatocellular carcinoma. So pathological sequence in HC virus, so it happens to acute, chronic, cirrhosis, portal hypertension, can lead to liver cell failure, or it can lead to hepatocellular carcinoma. So more common risk factor of hepatitis infections are drug abuse, multiple sex partners, surgery, last limb stick injury. So what is cirrhosis? Cirrhosis is end stage liver disease. So what it is? Formation of nodularity. Nodules. Most common cause of cirrhosis in UK is chronic alcoholism. In UK, alcoholism may lead to this. Most common cause of death is esophageal varices. So clinical features in portal hypertension. What happens? This the liver. It has got a portal vein, which is formed by sphenic vein, inflammatory vein, forms the portal vein, which opens into. So whenever the blood pressure rises in this, so that leads to congestion of the liver. Then the portal systemic shunts, esophageal varices, rectal varices, and all that. And there is lot of toxins, so they are retained inside. So this leads to decrease detoxification. So detoxification that leads to gynecomastia. It can be because of hepatorenal syndrome. So again, it can cause pressure on this kidneys. Toxins got so detox mental status. Then it can lead to coma, hepatic encephalopathy, gynecomastia, spider angioma, Palmer erythema, hyperesteronism. So this can lead to jaundice. So there is decreased protein synthesis, decreased albumin, and coagulopathy. So these are the things which can be seen. Finally, it may lead to hepatocellular carcinoma. So necrosis is the death, the membrane, cellular enzyme leak out of the cells. So leak of cellular cytoplasmic enzymes. There are different types of necrosis. It can be coagulative, liquefactive, fibrinous, gangrenous, gaseous. So liquefactive is some generally seen in brain, abscess. Coagulative seen in the initially in the brain, then it can lead to infarction. So gangrenous in the vessels, tuberculosis, gaseous, fibrinous again in the vessels, blood pressure. So in hepatitis there is hepatitis C viral infection. Hepatitis it leads to coagulative necrosis. Which are the different type of fungal infection? Candida, oral, vaginal, cutaneous, invasive. So these are the different. So 55-year-old persistent intravenous ulceration affecting distal leg. Again, RNA virus, hepatitis virus, debridement is required. So this leads to coagulative necrosis, liquid. Right iliac fossa pain, and then dilated appendix, and looks like a mass, esophageal abscess involving mucosa and muscular vessels. So you have to think of this can be a slow growing neuroendocrine tumors, NET, that is carcinoid. So what you think that it is from the neuro, most commonly found in, it is most common found in small intestine. It can be seen in appendix, terminal ileum, rectum, stomach, lungs. So what you test in this, in blood you test chromogranin A, or in urine you test 5-hydroxyindole amino acids. So immunohistochemistry can be done is chromogranin B. It releases some of the hormones like serotonin, histamine, bradykinin, substance P, tachykinins. So this leads to flushing and all that. Enterochromatin cells of liver can. So this can be fair. When do symptomatic? When it metastasis to liver. Most of the receptive GAT pass through the liver, but it reaches the body. Liver is strong enzyme break down and neutralize most of the serotonin and then substance produced by the carcinoma to prevent from reaching the tissues. When carcinoma metastases to liver, these substances more easily reach the tissues where they cause symptoms. Most common sites is liver. Signs and symptom of carcinoma spread is periodic. It can be periodic abdominal pain and cutaneous flushing, diarrhea-like symptoms. Patient has asthma, cardiac manifestations. What is immunohistochemistry? It is antigen antibody test. Procedure is antibodies and antigens are tied with the fluorescent dye and then looked into the microscope. Single point of procedure, they take antigens. So it's pathological thing, chromogranin B. After surgery, pseudomembranous colitis is suspected, signs and symptoms. Now pseudomembranous colitis. This happens because of chronic antibiotics use, and this has to be done that abdominal pain, diarrhea, fever, colonoscopy has to be done to diagnose it, or ELISA test. So presents liver atrophy formicularis. It is generally a parasitic infection. So you find a tumor, it is T2MXMX. So T2 is less than 2 centimeter. For this, if it is less than 2 centimeter, appendectomy more than 2 centimeter, it is right hemicolectomy. Is regarding 78-year man. The man of 78-year-old age is having black discoloration of grade 2. So this is about gangrene. So how are the questions regarding gangrene? So what can be the pathology? Grade 2, generally this is a dry type of gangrene. Then what are types of cell death? So what different types of cell death can be? Cell death can happen by necrosis or apoptosis. So necrosis is pathological, apoptosis is physiological. So this is patho, this is physio. So what happens? The nucleus size, there is a cell, it has got a nucleus inside, and these are various organelles, mitochondria and all that. Then the granular, this is cytoplasm, granular it is there, and this is cell wall. So in necrosis, what happens is there is swelling. In necrosis, the nucleus is swollen, while here in apoptosis, nucleus shrinks. Then it gets caryolasis, breakdown of nucleus is there, and this is just shrinking. Then plasma membrane, here it gets disrupted. Plasma membrane, cell membrane is disrupted, while here it is intact. Now, so invariably pathological, this is pathological, this is. So with different types of gangrene are wet and dry. So wet gangrene, this is commonly seen most commonly seen in the bowel wall, and this is venous obstruction. This is seen most commonly in the limbs. This is arterial. So blood supply when reduced, it leads to venous and arterial. So there is a line of demarcation in dry gangrene, while in wet gangrene you cannot see the demarcation. And toxemia is severe in wet gangrene. There is severe toxemia. So gangrene surrounding area show redness in because of pathological process, vasodilatation. What are the pathological cells present in atheroma? So atheroma. So these are macrophages, also called as sperm cells and lymphocytes. So why does clubbing occurs? So fingers clubbing, it occurs because of vascular epithelial growth factor. So that leads to loss of that window. Then apart from hypertension, diabetes and male sex, what are the major risk factors of atherosclerosis? So what are common risk factors for atherosclerosis? So this can be smoking is very common, diabetes mellitus, hypertension, age, more age, then increased lipids, hyperlipidemia. So if which size and type of vessels? Vessels is large and medium size. Then X-ray shows if the X-ray has got plaques. So what does it indicate? So this is very important. Pleural plaques. Collagen. It is deposition of dense collagen, and this may get calcified. So this we have to remember. The significance is there is increased risk of malignancy called mesothelioma. Thelioma. So, or bronchogenic carcinoma. So now different types of lung cancer, small cell, non-small cell, small cell, non-small cell lung cancers. So which is the best and which is the bad? So in the order of prognosis from best to worst. So best to worst prognosis. SLEM. S is squamous, L is large, this is adeno, and small cell. Small cell has got the worst prognosis. So best to worst. Squamous is best, large cell, then small cells is the worst, and adeno is in between. Single bedside test. So bronchogenic carcinoma, you will do sputum and send it for cytology. So patient is presented with meds, so prognosis will be very poor, and how to diagnose it is immunohistochemistry. Tumor is epidermal growth factor positive. Epidermal growth factor positive. So what can it be? Which is this chemotherapy agent is appropriate? So here you have to use tyrosine kinase inhibitor like imatinib, IMATINIB, imatinib. Which type is respond to tyrosine kinase? So small cells. Here it is given. Treatment of other types of lung cancer, platelet, PDL1 and inhibitor programs, cell death programs. So different types of necrosis. Again, the questions will come: coagulative, liquefactive, gangrenous, then fat, fibrinoid, caseous. The different types of necrosis. So adenocarcinoma is epithelial and glandular epithelium origin. What is emphysema? The question can come: what is emphysema? This is something like whenever there is chronic obstructive pulmonary disease, there are alveoli are damaged, and because walls are weak, the wall are weak and they rupture. These alveoli rupture, and that leads to emphysema. This is due to deficiency alpha 1 antitrypsin. So this reduces increase the surface tension so that it can be inflated. So when this is reduced, there will rupture. Then what is paraneoplastic syndromes? Neoplastic syndrome. So there is a malignancy called small cell carcinoma, and then it secretes different hormones or other things, indigenous hormones that lead to, that is called as paraneoplastic. Which are the hormones? Small cell lung cancer, they secretes ACTH, ADH. So these are the small cell lung cancers and parathormone related peptide causing increased calcium level. So what is tumor necrosis factor? Tumor necrosis factor is pro-inflammatory cytokine and produced by macrophages, leading to inflamed tumor necrosis, fever and all that. What is platelet-derived growth factor G? So this is platelet-derived growth factor receptor alpha gene, the tyrosine kinase families. What is FISH? FISH. So hybridization, fluorescence, and H is hybridization. This is in situ hybridization. This is cytogenic technique. Fluorescent probes are used. So this is about the lung cancer. So coming to the next station, here is a lady known of ulcerative colitis. The lady has got ulcerative colitis, and the lesion is less than 1 centimeter, and what you get is that lady is known to have ulcerative colitis, and colonoscopy reveals lesion is less than 1 centimeter, semi-colon. So what is UC, ulcerative colitis? It is an chronic inflammatory lesion, disease of the colon. So it can be any part of the colon, inflamed process to mucosa. It is basically mucosa, and rectum is always involved. So etiology is ulcerative colitis is idiopathic most of the type, immunology or environmental, maybe genetic. So commonest site is rectum. What is meant by backwash ileitis? What happens? There is this is transverse colon, ascending colon, then descending colon, sigmoid and rectum. So rectum is commonly involved, and at this junction there is ileum. So ileum is like this. So backwash ileitis means involvement of terminal ileum. This is terminal ileum. So this terminal ileum is also involved to long-standing ulcerative colitis with no escape lesions. So this is extending into the ileum. Or treatment? The treatment is total proctocolectomy. Means you have to remove, this is ileum for example, and you have to remove and bring it out, ileum, like ileostomy outside, and you have to remove all this, total proctocolectomy. The whole colon is susceptible because it has got very escape lesions, and if there is liver metastasis, how it will be M1. Now, what is the different microscopic feature in ulcerative colitis and Crohn's disease? So two different things. So ulcerative colitis has got crypt, abscess, and this is granuloma. So Crohn's disease, granuloma, and this is abscesses, crypt abscess. Lesion lamina propria. So what you see in colonoscopy, now you findings in colonoscopy, these are pseudopolyps, and this is cobblestone, fissures, ulcers, thickened bowel, and this is extensive ulcers. So prominent clinical feature in ulcerative colitis. So what you find is diarrhea, crampy pain, abdominal pain, tenesmus, bleeding per rectum, bleeding per rectum. So extra intestinal manifestations. So this is very important. Manifestations along with this, there can be, so person may have many different. So complications, what can happen are, so these are the complications. So what are the situations in which you need, what can complications can happen, like toxic megacolon, or there can be cancer of the colon, or there can be malabsorption. So these are the things that can happen. So why does the patient have diarrhea? Why there is diarrhea in this? This patient is having diarrhea because of malabsorption, or this patient is having increased motility or infections. Then you have a patient known as Crohn's disease. Now the patient underwent terminal ileum resection but still diarrhea. Why? Because there can be relapse, or there can be short bowel loop syndrome and all that. So more susceptible to the renal stones because intestinal fat, malabsorption, binding to the calcium, chelating, and that leads to oxalates, hyperoxaluria. So that will lead to oxalate stones. So besides GIT, what are the other extra intestinal manifestations? It can be in the skin, it can be in the eyes. So this can be in the eyes, this can be in the stools, or what this can happen in the liver, joints, liver. So bleeding in there in the stool, intestinal, for example, pyoderma gangrenosum. So this is one thing. Erythema nodosum. So this is another. Eyes can be, there can be iritis, conjunctivitis, there can be episcleritis or uveitis. So what happens in liver is sclerosing cholangitis. What happens in the joint is arthritis, and other is clubbing FFS ulcers. Common is arthritis, very common. How do you investigate the patient suspected of ulcerative colitis? So now how will you do investigation? So it can be done by measuring the full blood count, then stool analysis, fecal calprotectin. So this is done, and fecal occult blood is also done. So barium meal follow through or CT abdomen, prothrombin concentrate to prothrombin concentration, then colonoscopy, but not in acute phase. Which type of deficiencies? Vitamin A, D, E, K, ADEC. This is fat soluble vitamins. So deficiency of this, and vitamin B12 also it can lead to. Does this patient need endoscopic surveillance? So endoscopic surveillance, yes, for colon cancer you need. So what are the different management ways? How will you manage? So it can be conservative, or here it requires lifestyle modifications, then diets, control on the diet. It has to be medical treatment by steroids, anti-inflammatory drugs, antibiotics, or the common is 5-amino-acetyl salicylic acid or mesasalazine. This is mesasalazine. Immune modulators. Surgery, if medical treatment fails, then surgery. What are the indications when you go for surgery? So surgery is required in refractory cases, patients having toxic megacolon, intestinal obstruction, or fistula, abscess, any complication. So what is tumor necrosis factor? Protein cytokines, functions of tumor activate macrophage, neutrophils, mediators, anti-tumor effects. What is the role of inflammatory tumor necrosis factor in IBD? So it causes inflammatory. So tight junction permeability, it increases junction permeability and influx of bacterial components activates immune response. What are the drugs that act against this? So anti-inflammatory drugs, monoclonal antibody. These are commonly MAB, monoclonal antibodies. So this is infliximab, ciprosilimab, or any mAb. What is the mechanism of action of these cells? These are monoclonal antibodies, immunoglobulins, monoclonal immunoglobulins antibody to tumor necrosis factor alpha. So these are interrupting immune systems, used mainly in steroid refractory, where they are not managed by the steroid. Then if you see a picture and ask what is there is a cobblestone appearance. A patient having peptic ulcer and presented with hematemesis, then OGD is done and it's showing gastric ulcer which is bleeding. So this is bleeding peptic ulcer, and lab result shows increased calcium. Past medical history use osteoarthritis on NSAID. Patient is taking the tablets. NSAID is smoker, chronic kidney disease, and dialysis. So this patient is already taking NSAID, now has ulcer and ulcer is bleeding. So what is definition of ulcer? It is breach in continuity of skin or mucous membrane or a defect. So there is a defect. So that is an ulcer. Risk factors are peptic ulcer disease itself. Its peptic ulcer disease leads to H. pylori, or patient is taking NSAID drugs, and patient is smoking. These are the risk factors. So how can NSAID causes peptic ulcer disease? Peptic ulcer disease, NSAID. It is topical irritant. Then prostaglandin is protective. It is anti-prostaglandin. Then by COX-1 inhibition. So it decreases the blood vascularity to the mucosa. Then it causes impairs barrier mechanism and leads to infection and interferes with the repair of the injury. So what is H. pylori? H. pylori is a gram-negative flagellar spiral bacteria. Spiral bacteria. It is a spiral bacteria. So after taking biopsy, what test is done to confirm H. pylori? It is CLO breath test, CLO test. So Campylobacter-like organism. How it is done depends upon urease. H. pylori. This produces urease. So urease causes gastric mucosa biopsy is taken during gastropy and medium is containing urea. So urease converts urea into ammonia. So that turns red, phenol red. That increases pH, changing color from yellow to red. H. pylori converts urea to ammonia, which increases pH, changing the color. Positive test. How does manage to survive in gastric acid medium? The production of urease, which converts urea to ammonia. So how does it survive? So generally acid should kill, but it produces urease. So urea, ammonia, increases pH. That's why that helps to survive. So what are the tests? Urea, breath test, stool for antigen. So these are the tests which is done. How can H. pylori colonize stomach? So it colonize in stomach. So it has got flagella that causes to move, and flagella allows bacteria to move and motile into the viscous mucus and urease ammonia to pH, adhesions breakdown, and then toxins such as encoded by cytol. How H. pylori induces gastritis? It causes gastritis. How? That is the inflammation because of ammonia, protease, and then phospholipase. So these are the enzymes which acts and causes. What type of cells in the gastric mucosal? So these are mucosa has got simple columnar with goblet cells. So what type of gastric cancer? Ca leads to adeno or mucosa assisted lymphoid tissue tumor, MALT tumors. What immune disease is associated with Hashimoto's, thyroiditis? It can be associated. How to treat symptomatic H. pylori? Now there is treatment of H. pylori, or it is eradication. It can be done triple drug, 7 days BD twice a day. What triple drug? Proton pump PPT, proton pump inhibitor plus metronidazole plus clarithromycin. Clarithromycin. It has to be 250 milligram. Metron has to be 400 milligram. Proton pump inhibitor or proton pump inhibitor plus, if you do, metronidazole not given, then amoxicillin 1 gram plus clarithromycin 500 milligram. This has to be double dose, 500. If metro is used, 250. If 1 gram amoxicillin. Mechanism of action of proton pump inhibitors. So how does PPI? So normally what is there? These are the gastric parietal cells. So it has got stimulation, different vagal stimulation and all that. So that causes gastric parietal cells. So there is hydrogen potassium pump. So this is called as proton pump. And there is enzyme called ATPase. So ATPase causes release of hydrogen. So it causes release of hydrochloric acid when it is stimulated. And proton irreversibly binds with PPI, binds here to stop action of the hydrogen proton pump inhibitors. So then that's why provide optimal pH for action of the cell. Now, what are the actions of hydrochloric acid? Why hydrochloric acid is required? It causes pepsinogen to pepsin, then pH for pepsin and digestion. It stimulates small intestine to release secretin, then or cholecystokinin, enhances absorption of calcium and iron. Calcium and iron into absorption in small intestine. So what are the causes of hematemesis in this patient? So what happens most of the time? Hypercalcium is there, increased gastric release, hydrochloric acid production, become bleeding. What are the common causes of hypercalcemia? Malignancy, hyperparathyroidism, renal failure. The patient history of recurrent renal stones, hypercalcemia is the common. Commonest cause of hyperparathyroidism. So this is about parathyroidism. So what is the commonest cause? It is solitary parathyroid adenoma. So what is meaning adenoma is a benign tumor, epithelial origin. It has to be diagnosed by cystin B or Fusel section found in the normal location, superior mediastinum, area. What Fusel section? It is simple words. So again, paraffin block and all that. Now about parathyroid glands. There are 4 parathyroid glands. You are given a pathology report of one gland. One gland report is showing 0.2 gram chief cells, and you get 3 glands oxyantic cells, oxyphilic cells. So interpretation is adenoma, so involution of the gland. What is mean chief cells and few oxyphil cells? How does compare to parathyroid hyperplasia? Chief cells has to be then clear cells. What are types? Primary, secondary, tertiary, and then this is about